see Katie is here.
Welcome, everyone. Good morning, good afternoon, good evening. Welcome to today's ICAP Grand Rounds on differentiated HIV service delivery and COVID-19. We will get started in just a moment, but just to let everyone know, next slide, please. We do have translation services available for today's Grand Rounds webinar. And just to note, please select the language that you would like to hear the presentation in. We are offering translations in French as well as in Portuguese. So you will have to select the little globe at the end, the bottom of your screen that says interpretation, and select the language of choice. So the presenters will be speaking in English and presenting in English, but you have the option, if you're joining us from our Lusophone or Francophone countries, to listen to the interpretation. So just a little overview of our agenda for today's Grand Rounds webinar. First off, my name is Fatima Tsiouris, and I am the Deputy Director of our Human Resources for Health and Development unit at ICAP headquarters in New York. And it's my pleasure to be today's host of this really wonderful Grand Rounds webinar. I will give some opening remarks, just sort of introducing everyone to what is differentiated service delivery and what do we mean by DSD in the context of COVID-19. And that will be followed by 3 presentations. Dr. Catherine Godfrey from PEPFAR will be presenting, our first presenter, followed by Tiffany Harris and then Peter Preko. And then we will open it up to question and answer. Just a reminder that if you do have questions, please use the Q&A box to type in your questions, and you can type in your question at any point during the presentation. And if you have any challenges with animations of the slides, or the slides are not in sync, please use the chat box for that. And please, if possible, just communicate with our communications team. As usual, we ask that you type in your name and affiliation into the chat box just to give us a sense of who's joining us virtually on this live Grand Rounds webinar. So next slide, please. So differentiated service delivery is a client-centered approach to the design of HIV programs that simplifies and adapts HIV services across the prevention, testing, and treatment cascade to reflect the preferences and expectations of various groups of people living with HIV, while reducing unnecessary burdens on the health system. There are 2 main types. Less intensive models are for people who are doing well on treatment, and then more intensive models for people starting care that have advanced disease and comorbidities that require more frequent attention and support. DSD is about the how of service delivery. So where, when, how often, and by whom services are provided. And there are a number of models. So there are facility-based models, but there are also community-based models, so bringing care to patients where they live. There are group models versus individualized models, and then there are healthcare worker-led models versus peer-led models. Next slide. In recent years, countries across the world have scaled up less intensive models for people doing well on treatment. This experience has provided very valuable framework for when the COVID-19 pandemic hit health systems around the world. And it was important to decongest health facilities and enable innovative and resilient responses as well as accelerating the scale up of DSD in many settings. Our speakers today will touch upon how DSD supported retention and resilience of the health system and ensuring patients stayed in care despite many countries facing the COVID-19 pandemic. So our speakers today are Dr. Catherine Godfrey, who's the Senior Technical Advisor for HIV care and treatment at PEPFAR, Dr. Tiffany Harris, who is the Director of ICAP Strategic Information Unit, and Dr. Peter Preko, who is the CQUIN Project Director. So the first presentation will be given by Dr. Godfrey, who is an infectious disease physician and Senior Technical Advisor for Adult Care and Treatment at the Office of the Global HIV/AIDS Coordinator. She has published extensively on treatment issues for people living with HIV. And prior to joining PEPFAR, she was at the NIH and received the Constance Wolfsey Award from the AIDS Clinical Trials Group for her scientific contributions to women's health and the Donna Davis Award for contributions to the community. She currently leads PEPFAR's COVID-19 response and is championing activities aimed at reducing mortality for individuals living with HIV. Over to you, Katie.
Thank you very, very much for that kind introduction. And I am very grateful to be here. And I will say that the collaboration with ICAP and with the CQUIN network has been a really fruitful and helpful collaboration. So I'm very happy to share with the group the things that we've been thinking about and our response in the time of COVID-19. Go to the next slide. So our focus really has been ensuring continuity of care for people living with HIV. It's been really important to really honor the commitment that we've made to the individuals who living with HIV that we've already started. We've tried to leverage PEPFAR supported health systems and infrastructure, and at the same time reduce the exposure of staff and HIV clients to the healthcare systems. And we've really tried to be as flexible as possible in helping our HIV program shape the response to COVID-19. Next slide, please. So the critical interventions really have been, the emphasis is on really convenient client-centered care. We want to minimize interruptions in treatment, support re-engagement in care, and de-link clinical care from drug delivery. In our guidance that has been published once a week and sometimes twice a week since the beginning of the pandemic, one of the first things that we said was that the critical intervention for all programs and individuals is to accelerate and complete scale up of 3 to 6 month multi-month dispensing and decentralized distribution for all people living with HIV, including pregnant and breastfeeding women. We want to promote the use of virtual platforms to communicate with recipients of care. And the one thing to say is really that differentiated service delivery is more than multi-month dispensing, as was explained by Fatima. It really does encompass a whole kind of mindset that includes client and convenience and client-centered care. Next slide, please. So one of the things that really happened during the COVID pandemic was really expanded eligibility for multi-month dispensing. WHO updated their guidance on MMD eligibility in April of this year and now recommends that people on ART for 6 months and responding well should be offered refills. However, in the setting of COVID-19, we've actually suggested that dispensing 3 to 6 months of supplies can happen even when the client doesn't meet eligibility criteria. This is especially true and especially important for individuals initiating therapy and pregnant women and children. So we've seen a number of country programs take this up. Mozambique, for example, has expanded MMD eligibility. Ethiopia has given 3 months of multi-month dispensing for people, pregnant and breastfeeding women, newly identified clients, and people who are receiving enhanced adherence counseling. And there are other examples, Malawi and DRC for sure are among those groups. Next slide, please. So we began looking at, I'm going to first talk about multi-month dispensing, and then I'll talk a little bit about sort of the intellectual shift that happened over the last year and a half of COVID-19. So we began collecting data, PEPFAR began collecting data in fiscal year 2020, and it's collected quarterly in 51 countries. What we collect is the number of ARVs are dispensed into 3 categories: less than 3 months, 3 to 5 months, or more than 6 months. Next slide, please. And we actually have found that 30 countries. We went and looked at the guidelines for each of the 52 PEPFAR countries, and we found that 30 countries have changed MMD guidelines since the beginning of COVID-19. Next slide, please. And here you can see this represents the percentage of all PEPFAR supported clients on treatment, looking specifically at the number of months of ART dispense. The 6-MMD went from 9 to 16%, representing a 78% increase. So you can see that on the slide there. And you can also see other gains in the analysis. 3 to 5 months multi-month dispensing represented in the gray bars increased by 25%. So these are really big. Our country programs really embraced this idea and took this on. Next slide, please. So pediatric multi-month MMD increased 50% from 31 to 45%. In general, 6 MMD is not recommended for children, largely based on the idea that dose adjustment may need to occur. I'm not a pediatrician, but I do wonder if that may need to be revisited. From my pediatric colleagues, they emphasize that the reality is that dose adjustments are not that common. 3 dose changes are predicted in the first 2.5 years of life, then another 3 until the age of 10. After 25 to 30 kilograms, no additional dosing is anticipated. So we're actually recommending, and recommended in our last guidance, that that all kids over 5 should be offered 6-month multi-month dispensing. Next slide, please. And you can see some of the country-led adaptations. So in Mozambique, for example, really delivery adaptations facilitated growth. And what happened was that there was a big campaign that was very creative that looked at it saying it's a good time to look back at your health. So really thinking through what good treatment looked like, client-centered treatment looked like. Next slide, please. So next slide. So implementation of these things is a little bit different. There's a lot that goes into multi-month dispensing. There's the supply chain, there's a facility level planning, and client and community engagement. All these 3 things have to be in place in order to really achieve multi-month dispensing. Next slide, please. I have learned a lot about the supply chain during COVID-19. One thing that I learned was that most ART manufacturers that supply PEPFAR are based in India. Early in the pandemic, there were significant delays. Raw materials, which are sourced in China, were affected by port closures. And lockdowns in India meant that manufacturing plants were operating at significantly reduced capacity. So the United States government, working collaboratively with the government of India, got pharmaceutical workers designated as essential workers. But one thing I learned was that pharmaceuticals require packaging and labeling, and these workers were not essential workers. And then there's all kinds of delays related to international borders, specifically in Africa coming in from the port of Mombasa. And in country, there's illnesses that lead to further displays. So PEPFAR maintains central buffer stocks of ARVs. And early in the pandemic, this stock was accessed to replenish facilities. And this led to a apparent shortage of central supply. this was widely reported in the press, but it really was a deliberate strategy to ensure local access to essential medicines. So what happened is that we actually recommended requantification of need at a facility and at a regional level, which led to changes in standard operating procedures and early placement of orders. Next slide, please. Community engagement has been a really important part of our of the upscaling of multi-month dispensing, involving community health workers, patient navigators, and psychologists to really improve treatment literacy and support clients newly enrolled on MMD is a critical element. And we've needed to couple multi-month dispensing with community-based drug distribution. Next slide, please. Within the facility, we've recommended early ordering of drugs and focused support to sites with low uptake. We really promote a family-centered approach that aligns pickups of parents and children. Laboratory supplies were also affected. We developed priorities for both viral load and TB testing, and demand for viral load testing did go down. Early programmatic data suggests the viral load suppression overall is similar to pre-pandemic weeks levels, but we've seen fewer tests. I will say that we're trying to use the drug delivery model for other important supplies, for example, PPE. It's less well organized, but we're working through those details. Next slide, please. So as I've mentioned, we've been providing regular technical guidance throughout the pandemic. And again, as I do want to emphasize that the critical intervention is accelerating 3 to 6 month multi-month dispensing. Next slide, please. So part of the whole kind of concept is not just getting drugs out to people, but really thinking through maximizing engagement and re-engagement in the setting of COVID-19. It really is a challenge, but really our emphasis on shared goals and client-centered services. We understand that patients, there's a concept called churn, and patients come in and out of care. But the most important thing is really understanding and planning for disruptions and understanding the local context. Next slide, please. We no longer think of treatment as a linear process from aware to engage to establish on treatment. There really is a growing recognition that people will have cycles of engagement and disengagement. This happens at the best of time. And during COVID, there has been really some special challenges. Next slide, please. So we've actually tried to look at our data to see if we can identify certain individuals that may require extra intervention, and it has been really helpful. Here are the age and sex disaggregations, and one of the things that we can see is that women experience more treatment interruptions than men in nearly all age groups. And men and women over age 50 had significant treatment interruptions during the first wave of COVID-19. This is important because individuals over 50 are at highest risk for severe COVID-19 and may have other comorbidities that would put them at even more significant risk. So one of the adaptations that we are considering and has been rolled out in a number of countries is really using the differentiated service delivery models to deliver other medicines that might be required for this particular age group. And I think that this is an area that we really need some implementation science research and to try to understand how best to serve this critical group of individuals. Next slide, please. Here's another example where we can look at our data to evaluate interruptions in return. The blue dots represent interruptions, and the green dots represent returns. You can see that in Q3, in and around Kampala, the interruptions did not match the returns, but in Q4, the returns were greater than the interruptions. The PEPFAR country team believes that this represents lockdowns related to COVID-19. The caveat with these numbers with these data is that they are numbers and they don't represent a specific individual who interrupts and returns to care. But I think that looking at the trends can be very helpful. Next slide, please. So there's been several strategic program adaptations that have facilitated growth, and these are data from Mozambique, looking at some of the adaptations in response to the COVID-19 pandemic, including expedited rollout of tuberculosis preventive therapy with the multi-month dispensing. Routine remote psychosocial support by PEPFAR has been important, and you can really see that the dips in treatment numbers during the setting of COVID-19. So really, I think one of the things that we're learning is that local solutions are really, really important, and we can learn very much from our colleagues in country and developing solutions that may work in a variety of different places. And we are really interested in hearing specific adaptations. We've been really trying to be very responsive in the setting of COVID-19. So in summary, differentiated service delivery has provided a mechanism for improving continuity of care, for reducing treatment interruptions. This is not just trying to maintain the gains, but really improving the treatment for all people living with HIV. The evaluation, we're evaluating the impact of COVID-19 and continue to do so. It's a very dynamic process, but I'm hoping that treatment programs seem preserved. One of the things that we really are noticing and really trying to emphasize is that the local conditions and planning for interruptions is really, really important. And that planning for interruptions happens at both an individual level, but also at a programmatic level. I'm sorry, can you go to the next slide? This is the summary. So many COVID-related adaptations are quite helpful and are here to stay. And I think that we are really trying to make the best of a very bad situation. But there are a number of adaptations that really, honestly, are great and really help the clients. Next slide. With that, I'll just take a moment to acknowledge my colleagues who've helped provided help with some of these data, and I'll be happy to take questions, I believe, at the end. So over to you, Fatima.
Thank you so much, Dr. Godfrey, for that wonderful presentation, giving us sort of an overview of how PEPFAR has really supported differentiated service delivery models in the context of COVID-19. Our second presenter today will be Dr. Tiffany Harris, who is the director for the Strategic Information Unit at ICAP and is an associate professor of epidemiology at Columbia University. As the director of Strategic Information, Dr. Harris oversees the assessment and implementation of country and project-specific monitoring, evaluation, surveillance, and informatics activities, along with overseeing research projects in multiple countries. She directs the Strategic Information Unit team at ICAP and provides insight and direction to ICAP teams around the world working on dozens of projects supported by PEPFAR, CDC, and other funders. Over to you, Tiffany.
Thank you, Fatima, and thank you everyone for joining us today. I'm presenting this work on resilience to HIV services during the COVID-19 pandemic at health facilities in Africa on behalf of many colleagues and partners that you can see listed here. We've presented this work at a couple forums now, and it's currently being worked on as a manuscript. Next slide, please. So globally, as we all know, the COVID-19 pandemic has affected access to health services due to many reasons, including travel restrictions, fear of exposure at health facilities, and changes in national policies and redirection of human and other resources. And as Catherine nicely highlighted, in response to the pandemic, there's been an expansion of differentiated service delivery models, including things like multi-month dispensing. However, there's been a lot of other innovations as well. And so we really wanted to understand what was happening. So we examined the effect of COVID-19 pandemic on specific HIV services, including HIV testing, antiretroviral therapy, and viral load testing, as well as viral suppression at ICAP supported health facilities in 11 African countries. Next, please. We used retrospective, routine, aggregate PEPFAR monitoring, evaluation, and reporting data that was collected quarterly from October 1st, 2019 to September 30th, 2020. Just to remind everyone, quarter one, you can think about that as a pre-COVID-19 period. And then at the end of quarter two, in March, is when restrictions started being put into place. And for our analysis, we included data from 1,059 ICAP supported PEPFAR funded health facilities that reported HIV testing data in all 4 quarters. We included data from the 11 African countries that you can see here on the map, and also listed as the number of health facilities that we included from each country. We used this data to examine quarterly trends along the HIV testing and treatment cascade. And just to note, the data is for all age groups combined, unless otherwise noted. Next, please. So we also want to evaluate what the impact of the level of stringency measures in a given country may have had. So we dichotomized these 11 countries based on their median score of the stringency index created by Oxford University. And this is a composite measure that's based on 9 pandemic responses that you can see listed here. And so we divided our countries into more stringent, and that included Angola, DRC, Eswatini, Ethiopia, Kenya, and South Sudan, and those that had less stringent measures based on this score. And that included Burundi, Cameroon, Cote d'Ivoire, Mozambique, and Zambia. Next slide, please. Turning now to the results. You can see here on this slide, on the left y-axis is the number of individuals receiving an HIV test, which is represented by the green bars. And the right y-axis is the yield, which is the percentage testing HIV positive and is represented by the maroon colored line. The x-axis is the quarter. At the included health facilities in quarter one, over 511,000 people received HIV testing, and 4%, or 20,525, tested HIV positive. In quarter two, there was a 12.1% increase in the number receiving HIV testing, followed by a decrease of 3.3% from quarter two to quarter three, and an increase of 10.6% to more than 612,000 receiving HIV testing in quarter four. When we stratify this data by age and for sex for those over age 15 years and older, similar patterns were seen for testing. Next slide, please. And this slide, again, is the number receiving an HIV test, but here it's stratified by that stringency category. So health facilities in countries with higher stringency scores, which are on the left, showed substantial decreases in HIV testing from quarter two to quarter three, and then modest increases from quarter 3 to 4. While health facilities in countries with lower stringency scores, which are on the right, had increases in each successive quarter. When we compared quarters 3 to 4 to quarters 1 to 2, sort of a before and after comparison, there was a significant difference by stringency categories. And all of these patterns were consistent across age and sex groups. Next. Now going back to just HIV testing overall, this graph shows the number of individuals tested each quarter for each HIV testing point. And here, each color represents a different quarter, and you can see the different points of service for the testing there on the x-axis. And we can see that patterns differed by testing point, with the largest declines from quarter 2 to quarter 3 for both voluntary counseling and testing occurring as part of voluntary medical male circumcision services. Oh, next slide. Next. So here we see HIV testing by country and quarter. The y-axis again is the number tested, with each quarter represented by a different color. In most countries, there was a decline in HIV testing from quarters 2 to 3 and recoveries for quarters 3 to 4, just like the overall pattern. Next. For example, no, please go back. For example, in Mozambique, from quarter 2 to quarter 3, there was a decline of 3.5% in the number receiving HIV testing, and then an increase of 12.5% from quarters 3 to 4. Next. And now moving on to the next step of the cascade, ART initiation. The y-axis is the number newly initiating ART, and the x-axis is the quarter. Here, the pattern reflects what I previously described for HIV testing and new diagnosis. In quarter 1, over 23,000 people initiated ART. This increased by 7.5% to almost 25,000 in quarter 2, and then the number declined by almost 10% from quarter 2 to 3, and then increased again by almost 10% in quarter 4 to almost 25,000. When stratified by age, sex, and country, similar patterns were seen. And when stratified by stringency category, countries with lower stringency indices had less of a decline from quarter 2 to 3 and a larger increase from 3 to 4. And in statistical analyses comparing quarters 3 and 4 to quarters 1 and 2, there was a significant difference by stringency category. Next. This is new ART initiations by country and quarter. Again, on the y-axis is the number newly initiating ART, with different quarters represented by different colors. In most countries, there was a decline in the number newly initiating ART from quarter 2 to quarter 3, with an increase from quarters 3 to 4, reflecting the same overall pattern that was observed for number newly diagnosed with HIV. Next. As an example of this trend, in Zambia, the number newly initiating ART decreased by 15.6% from quarters 2 to 3, and then increased by 7.6% from quarter 3 to 4. Next. And now I will show you the overall number of people living with HIV on ART by quarter, which reflects both new initiations and individuals continuing on ART. The y-axis is the number currently on ART, and the x-axis is the quarter. In quarter 1, there was more than 419,000 people on ART, and this number increased each quarter throughout the time period to over 476,000 in quarter 4. When stratified by sex, age, and stringency, similar patterns were seen, and there was no significant difference found by stringency level. Next. Now, I'm going to share with you one of the key changes in ART programs, which is the adoption of differentiated service delivery model, multi-month ARV dispensing. Katie also showed you some data on this. And similar to the data that she showed for all PEPFAR countries, each quarter is along the x-axis here, and the colors represent the different amounts of ARVs dispensed. The yellow color, less than 3 months, the brown color, 3 to 6 months, and the maroon color, 6 or more months. And just like PEPFAR countries overall, we found that the quantity of ARVs dispensed increased over the year, with the largest increase noted from quarters 2 to 3. And by quarter 4, 80% of those on ART were receiving 3 or more months of ARVs. Next. Next, we're going to move to the last step of the cascade, viral suppression. The left y-axis has the number receiving a viral load test in the last 12 months, and this is represented by the blue bar. The right y-axis has the percent who are virally suppressed, and this is represented by the dotted purple line, and the x-axis is each quarter. In quarter 1, over 250,000 individuals on ART have received a viral load test in the past 12 months, with 87.5% achieving viral suppression. The number receiving a viral load test in the past 12 months increased throughout the year, with slight increases in the percentage with viral load suppression, with 90% of those on treatment achieving viral suppression in quarter 4. Similar patterns were seen when stratified by age, country, and stringency level, and there was no significant difference found by stringency level. It is important to note that at a population level, we are still seeing sustained high viral load suppression with the adoption of MMD. Next. This slide is looking at viral load testing and suppression in the last 12 months among females and males aged 15 years and older. And you can see that females and males are represented by different colors. And for both viral load testing and suppression, similar patterns were seen by sex as we're seeing overall, with both over 90% of males and females achieving viral suppression by Q4. Next. Lastly, I will show you viral load suppression data by country and quarter. In this slide, the percent virally suppressed is on the y-axis, and the different colors represent the different quarters. And the dashed line represents the UNAIDS 2020 target of 90% of individuals on ART achieving viral suppression. As you can see, most countries, 90% or more of individuals on treatment were virally suppressed. Next. For example, in Eswatini, over 96% of individuals at these health facilities achieved viral suppression in all 4 quarters. Next. In summary, our findings from over 1,000 health facilities in 11 African countries observed over 1 year showed mostly transient effects of COVID-19 on HIV services, with evidence of rapid recovery. From Q2 to 3, the number of persons testing for HIV decreased, with associated declines in the number of positive persons identified and number of new ART initiations. However, from Q3 to 4, we noted a recovery in both HIV testing and new ART initiations. And over the entire year, there was an increase in the overall number of persons on ART. Viral load suppression remained high, and this was in the context of expansion of multi-month dispensing. Based on our experience, rebound was brisk, demonstrating HIV program resilience, likely due to the expansion of differentiated service delivery models and other innovations, including expansion of multi-month dispensing, as noted in our findings and as Katie highlighted, but also innovations such as ART distribution in the community and virtual adherence consultations. Next. I would like to thank the various ministries of health in 11 countries, the health facility staff, headquarters, and in-country USAID and CDC teams, partner organizations and recipients of care, and ICAP in-country and headquarters staff, and funding support from PEPFAR, USAID, and CDC. Thank you.
Thank you, Tiffany. We'll now move on to our last presenter, Dr. Peter Preko, who is the project director for ICAP's 21-country CQUIN network, learning network, which you will hear about momentarily. Prior to his current role, Dr. Preko worked as the Senior HIV Care and Treatment Advisor seconded to the Ministry of Health in Malawi, and has worked with CDC and Eswatini as their care and treatment lead. He has also held a number of positions leading and supporting HIV/AIDS program activities in his native country of Ghana, including co-founding a local NGO called AIDS Alley that provided care and treatment in Ghana prior to the national AIDS response. Over to you, Peter.
Thank you very much, Fatima. And good morning, good afternoon, good evening to you all. Thanks to ICAP leadership for the opportunity to do my maiden presentation at the ICAP Grand Rounds. I'm already having palpitations, but I'm excited to have this opportunity, so thank you. I'll be presenting DSD program innovations and adaptations in response to COVID-19, focusing on lessons from the CQUIN network. And I would like to start by thanking the DSD coordinators who helped us to collect this information. Next slide. So this is my presentation outline. I'll start with a brief overview of CQUIN and then give a summary of the key DSD policy adaptations from the network countries, and then conclude with country-specific case studies. Next slide. So the HIV Coverage Quality and Impact Network, CQUIN, is a 21-country learning network designed to work with Ministry of Health as our key, or one of our key stakeholders to advance differentiated service delivery to achieve HIV epidemic control. This unique network is funded by the Bill and Melinda Gates Foundation and is convened by ICAP at Columbia University. It is supported by an advisory group that includes Ministries of Health, civil society, PEPFAR, CDC, Atlanta, USAID, Washington, WHO Global Fund, UNS, and the ITPC. We also have the Community Advocacy Network that supports the network with community engagement activities. The network focuses on bridging the gap between DSD policy and implementation. Next slide. So our main focus areas include knowledge and best practice exchange, joint learning in a collaborative, demand-driven manner, and innovations to generate new interventions, including data used for decision-making. Next slide. So over the past 5 years, working in close collaboration with our advisory group and other key stakeholders, and in a demand-driven opt-in approach, we have worked together to implement a lot of activities that country members see as very effective in helping to scale up DSD, also in improving network members' knowledge of DSD. And these activities include multi-country workshops and meetings, South-to-South learning visits, and also TA assistance that include supporting countries to develop guidelines, SOPs, DSD coordination, M&E of DSD and DSD performance reviews. To help countries improve their planning and coordination of DSD, we have also seconded national DSD coordinators to about 8 ministries of health. The network also supports communities of practice, about 8 active communities of practice, working together with interested countries to co-create tools and resources to address gaps and challenges that cut across the countries to help improve DSD implementation. The network also has a CQUIN website, newsletter that goes out every month, and a WhatsApp group, very active WhatsApp group in Francophone and Anglophone, where member countries share, exchange information on policies, guidelines, and as they update whatever new tools and resources that come up. Next slide. So South-to-South learning visits represent one of the key activities of the network, which is supported by ICAP. However, we have a lot of countries exchange experiences, resources, and tools through webinars, communities of practice, and on the WhatsApp platform, as I mentioned earlier. So we have multiple platforms for learning exchange, but one of the key ones is this South-to-South visit, which we've supported about 24 visits so far. Next slide, please. So tapping into the network's strength, ICAP quickly pivoted CQUIN's activities in the early days of COVID-19 pandemic to address the need for COVID information, as well as to facilitate exchange of country innovations on DSD policy and practice in response to COVID-19. So at very early stages of the COVID, we set up a COVID session on the CQUIN website where we're able to share country tools and resources, guidelines as they updated them. We also established a WhatsApp group for Anglophone and Francophone countries where both countries were able to share information, both on the platform, also online. And in collaboration with IAS and ITPC, we instituted a weekly webinar series where we're able to share country adaptations and service delivery policy and practice, along with resources, tools, and lessons learned. We also work with DSD coordinators to share monthly updates through a monthly calls that we had with them. Next slide, please. So now I'm going to take you through some of the policy adaptations and practice that the countries implemented. Next slide. So from between April and May 2020, we surveyed 40 member countries that were part of the CQUIN network at the time. As I mentioned earlier, we now have 21 countries, but in April 2020, we had about 14 countries at the time. So we surveyed these countries to understand the impact of COVID-19 on DSD policy and implementation during the first wave of the pandemic. And we observed that within the early weeks of the first report of COVID-19 in Africa, all the 14 countries had made substantive changes to their national DSD policy, DSD programs. Next slide. So in the survey, we asked countries to answer about 6 questions. We asked them to let us know if they are expanding eligibility criteria for multi-month dispensing, whether they are moving to 3 MMD or to 6 MMD, whether they have MMD, multi-month dispensing for non-ART medications like NCDs or TB medications, and whether they were stopping or suspending any DSD models or making changes to how group models work. And finally, whether they are changing how lab monitoring is done. Next slide. So we observed that the most common adaptations was the expansion of MMD to decrease health facility visit frequency. And I think you've seen some of these slides from Dr. Katie and Dr. Tiffany's presentations. So about 10 countries expanded multi-month eligibility, which include about 4 of them that waived their requirements for viral suppression. So people were put on multi-month dispensing without being virally suppressed. So they removed the eligibility for having viral suppression to be enrolled in multi-month dispensing. 6 countries permitted MMD for people initiating ART, and 3 permitted MMD for pregnant and breastfeeding women, including children who are virally suppressed. There were 7 countries that increased the amount of ART dispensing through multi-month, and 9 countries that enabled multi-month dispensing for TB preventive therapy. Next slide. So some changes were also made to improve social distancing, and this include canceling or redesigning group models. So there were about 8 countries that canceled at least one model, which include either a facility-based group model or teen clubs. Countries also, in an attempt to see patients at convenient hours, they increased their clinic hours. Some improved fast-track refills so that recipients of care spend less time at the facility. And then there was a significant expansion of community and home-based drug delivery as well. Next slide. So I'm now going to take you through some country-specific examples. Next slide, please. And I'll be starting with Sierra Leone. So Sierra Leone was in their planning stages of DSD rollout when COVID started. However, they were able to quickly throw out all the cautions that they had and rapidly introduce 3 MMD for all people living with HIV, including for new ART initiations, pregnant and breastfeeding women, children, and even people on TB medication. Also, in partnership with stakeholders, they were also able to introduce 3 MMD community-based refills and home-based delivery for those who could not come to the facility due to distance or the curfew that was in place at the time. Next slide. Mozambique also pivoted to virtual patient follow-up and program monitoring. So psychosocial counseling, delivery of high viral load results, and provision of enhanced adherence counseling were all done by phone. The program also introduced monthly Zoom calls with the provincial HIV teams so that they could discuss challenges and best practices that informed the updates to the guidelines that they were updating frequently. One very important innovation by Mozambique, by the Mozambique program, was a virtual training to help providers document people put on DSD. People who were put on DSD because of COVID, because of the COVID relaxed guidelines, versus people who were put on less intensive DSD models using the former eligibility criteria. I really call this like a differentiated documentation of DSD eligibility. So they were able to differentiate between COVID eligibility versus, truly established on ART eligibility. So I think moving forward in terms of data analysis, they will be able to tell which of the people on 3-MMD or less intensive DSD models is as a result of COVID regulations versus those who are actually eligible based on their pre-COVID guidelines. And I thought that was very interesting. Next slide. Eswatini was one of the countries that has more mature DSD program at the onset of COVID. And they actually considered 3-MMD as a standard of care for people who have been on ART for more than a year. So with the onset of COVID, they were able to quickly introduce 3-MMD for new initiations and children older than 2 years with suppressed viral load. They also introduced 3 multi-month dispensing for TB treatment, TPT, and NCD medications. Whilst they also were able to scale up 6 multi-month dispensing for people already established on ART, including for adolescents and those in community models. To enhance COVID prevention, Eswatini suspended teen clubs, community adherence group meetings, but however introduced outreach ART services to new communities. So they had some communities where clinics had to close down because the providers had to go on COVID isolation because staff got COVID, and because all of them were exposed, they had to close down the clinic, but they were able to quickly introduce outreach refills to those communities. Next slide, please. Zambia, on the other hand, kept the Zambezi River flowing throughout COVID. So they didn't institute any specific policy change due to COVID. However, they made sure that they had policies in place. They reinforced their existing DSD policies in order to protect both patients and both recipients of care and health providers. So they strengthened their monitoring systems to ensure that 6-MMD was scaled up, and most of the people on treatment were then put on 6-MMD. And by doing so, the community adherence groups naturally disintegrated as people switched to 6-MMD. But then they were also able to scale up 3-MMD for children who are older than 2 years. They were able to align TPT refills with ART refills. So they were providing 6 multi-month dispensing of TPT if you are on 6-MMD. Zambia was also compelled to halt TLD transition because of concern for TLD security. Their community groups, they didn't make any changes to their community groups, but they encouraged them to wear masks and also to ensure physical distancing during meetings. Teen clubs also continued, unlike in other countries, except that they reduced the group sizes and also limited the meeting time. Next slide, please. So DRC was also able to expand multi-month dispensing and introduce mobile health to support patient monitoring. They introduced 3-MMD to all patients who were previously not eligible for less intensive models under the pre-COVID guidelines. And this includes people who are newly initiating ART, TB patients, pregnant and breastfeeding women. They then also introduced monthly phone calls to follow up this category of people who were under the previous guidelines, they would not have been eligible for for multi-month dispensing. They introduced monthly calls to follow them up for the first 6 months when they were given multi-month dispensing. And then they scaled up 6 MMD for those eligible for less intensive models under the pre-COVID guidelines. Next slide, please. Malawi also introduced the MMD for other medications and suspended routine viral load monitoring for those established on treatment. So with the exception of children, pregnant women, and breastfeeding women, but people with suspected treatment failure receive targeted viral load. So as I think Kitty mentioned in her presentation, they changed their viral load monitoring just to be able to provide, I think, more platforms for COVID testing, I think. PrEP and TPT initiation were also suspended, but if you had already been initiated on TPT, they gave you 3 months to be able to complete it. If you have been on TPT for 3 months and you don't have any side effects. Also for PrEP, if you have been initiated on PrEP, they will continue with 3 MMD for PrEP. HIV exposed infants received 3 MMD for cutting preventive therapy. And unlike other countries, Malawi didn't give 3 MMD for TB patients. Next slide, please. So the final country example is on Uganda. And as most of you already know, Uganda is well known for having a very strong community-led HIV program. And as COVID pandemic started, they strengthened this platform that they already have to make sure that they were able to deliver ART, uninterrupted ART to recipients of care. So they opened additional community ART distribution points to limit health facility visits. Implementing partners supported home delivery of ART using motorcycles, and community assurance groups were not suspended, but were encouraged to implement effective prevention and control measures. However, facility-based groups were suspended, and MMD was recommended for everyone, regardless of age or viral load status, with a few notable exceptions. Next slide. So in summary, the CQUIN network was able to quickly adapt, CQUIN network countries were able to quickly adapt DSD policy and practice to help sustain service delivery and program resilience. And adaptations were also put in place by healthcare workers in recipients of care in the center. Sorry, adaptations put both healthcare workers and recipients of care in the center in order to protect their lives. And finally, the CQUIN pivoted activities. The CQUIN was able to pivot its activities to be able to track and share information and best practices on DSD policy and practice. And we hope that we will continue to do this to see how some of these policies are maintained or whatever changes are made to it. Finally, next slide. I would like to invite you all to the CQUIN website, where you'll find more information on our the DSD and COVID response by CQUIN network countries. Thank you very much.
Thank you so much, Peter. Unfortunately, we're running short on time, but I will take moderator's prerogative to ask one question to all 3 panelists. All 3 of you presented really wonderful innovations that were implemented to support DSD and ensuring patients remained in care. Can you just very briefly, what do you think should be sustained after COVID? So based on some of the examples and innovations that were implemented, what should remain as part of policy and program implementation beyond COVID-19?
Well, I don't mind starting. I really think multi-month dispensing with expanded access to it is really, really important. The separation of clinical care from drug delivery is critical. And I think that we've also, the other piece that I think is really important, and it's a place we've been going to for a while, is really emphasizing what is it that the client needs and the client wants in terms of care. I think that those are the big things for me. Over.
I would also agree with that. I guess the other thing I think we should just keep in mind is, people may need to go to the health facility for other things, family planning, TB treatment, even chronic diseases as our people living with HIV age. And so we just want to make sure services are integrated and we're not switching to, multi-month dispensing for, say, our HIV drugs, but someone still has to go in every month to get their birth control, right? So I think we just need to make sure our programs are in sync and coordinated and done in an integrated manner.
And I think just to add, for me, I think that I was very happy to see the scale up of 3-MMP for children. And I think it was an area where countries were very hesitant. And with COVID, we saw that they were able to make it happen. And if that can be sustained, I think that would be great, especially for the mothers who have HIV and also kids who also need treatment.
Great. Thank you so much to all three presenters. Just before you sign out, I'll ask that you respond to the questions that have come up in the Q&A box so that our participants get a response to the questions. I just want to thank everyone for joining us today. I think we learned some really great innovations on how to ensure resilient health systems. We heard about policies, SOPs, the need for different models of care to ensure that patients receive the care they need in the places that are right for them, whether it's at the community level or at the facility level. And lots of lessons learned that could be leveraged and applied to other diseases as well, including non-communicable diseases, TB prevention and treatment, family planning, maternal child health. So lots of learning. And we know that many countries, including the United States, are still battling the COVID-19 pandemic. So we just want to ensure that everyone stays safe and be well. And we hope that you'll join us in September when we restart our monthly Grand Rounds webinar series. So for those celebrating or enjoying the summer vacation, please do enjoy and stay safe. Thank you so much.